Hello, everyone, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Health Recovery Solutions. Just a few housekeeping items to go over. We would like to remind everyone that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. Stay on after the webinar to be amazed by mentalist Mark Toland. And with that, I will throw it over to our moderator who joins us from Health Recovery Solutions, Nolan Santosa.
Hey everyone, thank you so much for joining us today. We are beyond thrilled to have this panel of really brilliant and experienced people to chat with today. So I'll just do a quick introduction and then we'll get right into the meat of things that we're going to talk about. My name is Nolan Santosa. Again, I'm the Vice President of Client Strategy at Health Recovery Solutions. And quick info on Health Recovery Solutions. We're the best-in-class remote patient monitoring and telehealth solution that works with the nation's largest providers and payers. Spends a lot of energy in the last year focusing on helping us all navigate this pandemic that we're still dealing with. And really, we're just hoping to continue to work with our great partners to build on their programs in telehealth, chronic care management, and clinical enablement. I've personally been lucky enough to work with hundreds of HRS customers in designing and executing their telehealth programs. And I'm really, really passionate about the topics that we're going to delve into today in terms of what organizations across the country are doing with telehealth and remote patient monitoring, how they're getting reimbursed for those services, and really just what the future looks like in a post-pandemic world. So just beyond thrilled to talk about this with this great group of people. With that, we're going to go through a kind of a quick round of introductions. So I'm going to start with Samir. Samir, I'd love it if you could just give a little bit of introduction on your role, your organization, and if you can talk just quickly for everyone about what you're currently doing with telehealth and remote patient monitoring.
Sure. Let me start by thanking you and the HLTH colleagues for this opportunity. I'm excited to share my point of view and learn from Rick and Katie as well. My name is Samir Badlani. I'm a physician by background and currently serve as the Chief Digital Officer and also the CIO at mHealth Fairview, based out of Minneapolis, St. Paul, serving the state of Minnesota mostly. Telehealth has been an important aspect of our delivery services. We look at it as a value solution in providing access. And like many other companies in this space, during COVID, we were able to bring our presence in telemedicine, synchronous care, asynchronous care, to serve the community that could no longer come into our clinics and hospitals in many cases because of the COVID pandemic. So it's a very important aspect of our delivery model. I have some other thoughts on why I think it's so important and vital. As I mentioned earlier, I just don't call it innovative or game-changing. It's been around for 20 years, and I think in healthcare, we're finally learning to use it to our advantage and to do well for our consumers.
I think that's such an important point, Samir, that it has been around for a while, and I think the pandemic really has brought to light how essential and vital this is for our daily operations as healthcare providers. So we're really excited to dive in more as to how we can kind of develop those sort of sustainable programs. With that, Rick, I'd love for you to tell us a little bit about your role and also about what you're currently doing with telehealth.
Absolutely. Again, honored to be here. I'm Rick Abbott. I'm the Vice President of Product and Market Solutions here at Premera Blue Cross. We are a 2.4 million member Blue plan that serves Washington and Alaska as our primary markets, but we actually have members in all 50 states. So obviously we'll talk about later how telehealth, particularly within the Blue system structure, is critically important in our ability to deliver care to our members. Our group is responsible for everything from virtual care through how we use networks strategically to drive down costs and improve quality to how we deploy other solutions that are more clinically focused. Obviously, 2020 was a year where we received a lot of accolades for the work we did from a virtual care perspective that we'll talk about later. But similar to what Samir said, we had already started building that foundation well before, thinking about how we could deploy virtual care solutions in a way that would really meet members where they're at. And I think one of the things we'll talk about later is also where we're going and how we can use this as a means to improve cost efficiency, improve quality, and improve member experience, while even potentially improving the provider experience as well. So I'm really excited to talk about everything we're doing here and honored to be here with Katie and Samir.
Yeah, it's fantastic to have you here, Rick. And I think it's just so exciting, some of the the expedited growth that we've seen with telehealth throughout this past year. Having to run quickly, and a lot of organizations have stepped up to that challenge, and certainly yours is one of them. So it's really exciting, and we're excited to dive into that a little bit more. So let's turn to our final panelist, Katie. Can you tell us a little bit about your role and what you're currently doing with telehealth?
Thanks, Nolan. I'm so honored to join Rick and Samir today. And I'm the Senior Director for Strategic Initiatives for Brookdale Senior Living's Healthcare Division, which is comprised of skilled home health, hospice, and outpatient therapy. We serve over 100,000 patients annually across 27 states. And this year we've implemented, or actually last year, implemented telehealth and remote monitoring across our platform to really offer that virtual care and remote monitoring for our high-risk patient population with conditions such as heart failure, diabetes, COPD, and of course, COVID-19. Really looking to improve outcomes and reduce our patients' risk of hospitalization or adverse events. And I'm excited to talk about this more today and how we've seen success from a provider perspective.
Great, Katie, and we're so excited to have you here too. I think there's, remote patient monitoring especially has been around on the post-acute side for a long time. And so, identifying how that fits into the overall continuum is definitely something we want to dive into today. So, before we get in too far into future state, I want to talk a little bit just about where we are today and kind of how we got here. So I think, an interesting place to start is, Samir, I'm going to turn it back to you. I'd love to just get your thoughts on kind of the lessons learned throughout this year, because I think a lot of organizations probably had to move a little bit faster than they expected to stand up programs to address the needs of COVID. And I'm curious, kind of in that process, as you've kind of looked at this system wide, what have you learned? What advice would you give the other organizations that have gone through that process?
Sure. I think the biggest lessons we learned collectively were threefold. One is we had a perception that patients don't like telehealth. So, when I go on my angry rants about telehealth being around for 20 years, I did my first telehealth visit 20 years ago. Why hasn't this picked up? One of the biggest notions we have is that patients don't like it. The second one we had is that physicians don't like it, that physicians feel like they would be providing less than ideal service and that their patients, would not have good health outcomes related to this. And the third bucket is that we felt this was an inadequate mechanism of providing care delivery. So those are the three major challenges with the telehealth expansion as I see it. A lot of people have focused on reimbursement. Let's put that aside for some other conversation point later today. But what COVID showed us is that neither of these three really hold any water. We were able to have a lot of physicians quickly pick up a lot of technological expertise in deploying telehealth. We had a lot of patients of diverse backgrounds, economically, racially, ethnically, whatever you want to pick, really get very comfortable quickly with having a telehealth visit. And the fact that for many, many things, it is appropriate and it's adequate. You don't have to make a patient drive to your center or drive to different parts of your state to receive care. And I think it really brought us to a more realistic value proposition of telehealth that I hope we continue building on.
I really love this concept of sort of demystifying telehealth, right? Because I think there are a lot of sort of negative kind of naysayers saying, hey, it's going to be too challenging, whatever it might be. And Katie, I know you've had to deal with that on the post-acute side with, dealing with elderly patients who a lot of organizations have maybe said, hey, we just don't think it's worth the effort. But I think you've had good results there. So can you talk a little bit about that from your perspective?
Yeah, thanks, Nolan. That's a great point and great question. We have just experienced that, to that point, that's not the case. We serve a senior population. Our average patient age is 85. And we've found that among patients using telehealth and remote patient monitoring, our largest participation bracket is between ages 70 and 90. So age is not so much a factor as is access to the technology. We've also found that between mobile and hardware solutions, there's not really a one size fits all. We have different patient populations with varying levels of financial resources, cognitive abilities, and access to caregiver support. So therefore, we continue to identify new and different ways to meet those varying needs to ultimately achieve better outcomes. And while we started with a mobile application solution and have seen great adoption even among older adults, we are planning to expand our solution offerings to include hardware and peripherals for patients that need that.
Yeah, and I think I love what you said there, Katie, about access of care, right? Because we sort of have to meet the patients where they are in a sense, right? Not everybody's going to be able to use sort of the same high-tech functionality. And so having solutions that make sense for each patient population, I think is a really great way to do that. And I know, Rick, you've done a lot of work in sort of diversifying your portfolio of solutions that you've looked at. So what are some of those lessons learned from your standpoint in looking at the different patients and members that you've monitored over the past year?
Yeah, we sit at a very interesting place in the relationship between provider and member, as we are essentially the place they go to find that provider, but not the ones in most cases that are delivering that care. We do own some primary care clinics, but for the most part, people are coming to Premera to say, help me get to the place that I need to be. We've taken the approach of being an aggregator and organizer of all of the different options that we have in the various ecosystem, whether they're virtual care companies based in San Francisco or brick and mortar systems that have built out that capacity over the past year or two, or in some cases, 20 years in Samir's case. And I think what we try to do is say, let us understand you in a very great detail. Let us understand the type of care you are seeking, even if you might not even know yourself, and let us point you in the right direction. We say often that we have about 2.4 million members, none of which are the same. Each one of them has individual needs, motivations, types of care. Some love the idea that cost and convenience can be incredible right now. I can get a $0 visit within 90 seconds. Others are really waiting for all the vaccinations to occur so that they can go back to seeing the doctor they've had 20 years. We view our role in that is making it easier to get there and helping you understand what that means. Again, from a cost, a quality, and an experiential perspective. You choose whatever value you place upon those levers, and we will just get you to the right place. The good news now is we have, because of last year, gotten to a point where the telehealth options are every bit as robust as the physical options as well. And the other last thing I'll say to this point is virtual care and telehealth allow us to bring very socioeconomically relevant, geographically relevant, culturally relevant care that might not exist, for instance, in rural communities from other places in the country. So we now can actually bring care to you where you might not have even had that care option in the past, and that's incredibly powerful as well.
I love that point, Rick, because I think it's so important to recognize the additional value. It's not just substituting what you used to do with something that is equivalent, right? It's also, what can we do that's better than what you had before? How can we bring in new people into the equation, new, consults and providers that you might not have had access to before? I think that's really, really important. Before we move on to our next topic, I just want to pose this to sort of the group, and Samir, maybe we can start with you. I think a lot of organizations have kind of stood up programs, and we know as we get into sort of the future state at the end of this conversation, some will stick, some will not. But tell me about, current results. Where are you seeing the most success right now, or what programs, that you've kind of stood up were sort of a resounding yes, this is something that is going to kind of stand the test of time in a pandemic world? What are your thoughts there?
Yeah, it's a great question. And let me start by saying this wasn't a surprise to us. It was more of a validation to my colleagues who are the experts in this space, and that is of behavioral health. I can speak a lot about the absolute burden of mental disease that has exploded, not just from what it was, but what has been added with the COVID pandemic. But we were always keen on expanding our telehealth, virtual health, which is a little more than just telehealth because it's pre-diagnostic asynchronous care, then telehealth, and then post-diagnosis asynchronous care assets in behavioral health. But when COVID, the first COVID peak that came about in about March or April of last year in our state, we rapidly expanded our capabilities in the behavioral health and almost had 90% of our previous volume being served through these three modalities. And yes, that's the direction we were going, but it was a tremendous validation that behavioral health, amongst many of other service lines, really lends itself very well to telehealth. Rick made excellent points about being socially economic appropriate, being geographically appropriate for everybody, not just people who live close to our main hubs, but anywhere across the country. If you take a step back and think about the life of a behavioral health patient, there is so much stigma still in our society. There are socioeconomic challenges of going to multiple appointments. It's not like your annual checkup or diabetic visit that you do once every 3 months. Repeated visits, crisis modulations. Telemedicine just lends itself so beautifully to taking care of these patients and minimizing the impact to their daily lives and supporting them. So we were very heartened to see that the notions we had about mental health burden and the behavioral health opportunity that could come from telehealth really play out that way. And I do feel that in the future of all our subspecialty services and our service lines, this is one that will have a very good story to tell in use of telemedicine. The other one that I like to speak about is primary care. I think it's time to really disrupt primary care, not at the edges, but completely blow up that model. This notion that I get good care because I go see a doctor or a nurse practitioner once a year is somehow keeping me healthy. That's just not the case. We need to preserve the little opportunity we have with our highly experienced doctors and nurses for patients who need it when they need it the most. And the rest of the care that somebody needs from a primary care perspective can easily be handled through asynchronous AI ML based care pathways that will actually achieve better results than if you came to me in spite of my 20 plus years of experience, because I can never meet you where you are in that journey of your health receiving and wellness. So really starting to look at telehealth as a wellness opportunity, not just solving for, I have X number of patients waiting to see me in my primary care clinic. So those would be the two areas that I would highlight.
Yeah, I'll build upon that. I agree. Behavioral health has taken a massive step forward in the past year. Some statistics I commonly highlight: prior to COVID, depression is the leading cause of disability in the entire world. 6 in 10 people who need mental health treatment do not go, and there are a myriad of reasons: financial, stigma, etc., access. And 9 in 10 people who need access to substance use disorder treatment do not seek it. And again, because it can be financially crippling, and it does require, for instance, some vulnerability with your employer or your family, et cetera. It's a courageous thing to actually step up and do. And some people, unfortunately, because it is so stigmatized, just do not do it. And then COVID started, and 1 in 3 people in this country, 110 million people, believe they have clinical anxiety or depression. So what at least 2020 did, if nothing else, is bring us to the forefront. And I totally agree that virtual care is a way that we can take a huge leap forward as a country to be able to solve for this problem as well. We've done a number of things on our side to be able to bring more access points. We've launched companies like Boulder Care that bring virtual opiate use disorder treatment to a patient, allows them to do, from a remote monitoring perspective, to your point, all of the necessary steps to be able to seek that care. We've been able to actually bring, again, culturally relevant, specific care from a behavioral health perspective to communities of color that perhaps understand the unique needs of that population better than, for instance, we might in Seattle. So again, one, from a stigma perspective, I think that's been broken pretty considerably. And then virtual care was really uniquely positioned to solve for that immediately. And I think that's really the greatest thing to happen in 2020.
Really interesting points from both of you. And I had a point I was going to bring up later, but I want to talk about it now because, Samir, I love what you said about kind of disrupting primary care, right? And so one of the areas that I think we can kind of demystify and talk about a little bit is there's been kind of this concept in the ether that, continuity of care, having the same provider every time you go is sort of this really important backbone of creating a good patient experience. And I think all three of you have probably had experiences to the contrary, mainly out of necessity, but also out of sort of innovation during this time. So Katie, let's go to you first, because I know we've seen this sort of play out in kind of the post-acute services. What's sort of your viewpoint on this continuity of care idea versus being able to be more agile, bring in more providers. What are your thoughts on that, and what have you seen?
Yeah, we've seen, this industry that we're in continues to suffer from shortage of nurses, shortage of different specialists. And so how can we bring the size and scale that telehealth affords us to reach the masses? And so while, continuity of care is utmost important for us and our patients, what we've seen is that we've been able to add value through specialty support through this use of technology. We can supplement our workforce, through this. We've engaged multiple disciplines such as social work, chaplains, wound care specialists, and really engage with the clinicians and the patient at the bedside with these other specialists. And so I think, while continuity of care is important, it's not the only solution. And telehealth certainly affords us the opportunity to, again, bring in additional support.
Yeah, and I'm actually going to build upon that. So one of the things we are doing this year is really focused on disrupting the primary care model. Yes, traditionally, the idea, as Samir said, of having one doctor over time who sees me once a year is seen as a primary care focused model. We actually believe, one, that it doesn't have to be one doctor. Potentially a virtual clinic can provide all of those services. And two, we can actually build an entire care team completely obsessed with helping you stay well, understanding where your care gaps may be, helping you close them while you go about your daily life. If you think about that model, we can build care teams from a telehealth perspective that can be comprised across the entire country of things like primary care doctors, licensed clinical social workers, therapists, nurses, the ability to deliver home care, organize them in a way where the patient doesn't even need to think about it, and deliver care in a virtual manner. Again, at that clinic level, where perhaps we contract with an entire virtual entity to manage the patients, but that doesn't have to always be Dr. Wiseman. So that really allows us to really disrupt that model in a pretty substantial way, and allows us to use the resources that are available across 50 states as opposed to the resources that might be available within the walls of one particular office. And I think that is transformative for this industry.
Yeah, that's really great points from both of you. And I think that that's a key piece that has kind of unlocked a lot of the programs that we've seen this year is being able to think outside the box and say, we know this is the old way of doing things, but how can we do this better? How can we do this more effectively? And I think, Katie, to your point, with the shortage of staff, the rising need of patients, we're going to have to adapt in order to kind of survive and make sure we can meet those needs. I want to shift the conversation now into talking a little bit about reimbursement. We all know patient care is at the forefront of this, but I think there's been a lot of changes in reimbursement this past year that have kind of enabled providers and payers to do some things a little bit differently. And I think there's a lot of uncertainty moving forward as far as what do those continued changes look like, and is that going to remain in place? So Samir, I'll come back to you. Would love to hear just your kind of general thoughts on how does reimbursement play a role in your telehealth strategy, and where do you see that kind of playing out moving forward?
Yeah, I mean, like all things in healthcare, reimbursement plays a big role. Let's just acknowledge that up front. It's great that right now we have this somewhat of an emergency, ruling that telehealth visits, video visits especially, get paid at parity. And I would like to see that continue, but it's not as simple as that. We need to really start differentiating that a telehealth visit, when appropriate, gets full parity, when not appropriate, doesn't get full parity. So we have to get more nuanced around it. One of the things that I like to point out is sometimes we have this conversation that video visits are at parity, but just audio visits are not at parity. That's a big problem in my opinion, because as much as we all agree that our seniors in different parts of the society are able to transition to video-based visits, there are places across the country where people don't have access to good Wi-Fi or bandwidth so that they can actually run a good quality video visit. There are significant portions of our community, whether it's due to age, education, or any other disability type reason, can't handle technology as well as the rest of us can and don't even blink about it. So from equity of access, I think it's really important that we keep an eye on how we change the parity rules associated with telehealth and then break it down into video versus audio. So that's one element of it. The other thing I would say is fully expect that there will be some change. I'm not sitting here thinking that, this is just going to continue forever. But what it is doing is that it's shown us how it can work. It's shown us how well it can work, and maybe in places where it doesn't work. So how do you look at telehealth from the perspective of not as a replacement for in-person visits, but as Katie pointed out, in some cases supplementing, in other cases enabling, and as Rick pointed out, in some cases maybe even that being the only way you provide some services. And we really need to go back to the drawing board and create business and operation models that take advantage of what telehealth brings to the table, and then build our entire business model from that particular perspective. I'm sure all of us, hear all over the country how digital, all of us are digital companies. We just don't know it yet. And we happen to provide healthcare or happen to provide senior care and so on and on. I think that's absolutely true. But there is still a good 3 to 5 years to go for at least healthcare delivery, where corporate strategy and digital strategy become overlapping, even if they're not one and the same. So this is our opportunity, while the reimbursement is what it is, to get creative around a business model where you solve for access, you solve for better opportunity to serve our community, and through that improve our margins, and think of telehealth as more as the cost of doing business versus an unreimbursed activity.
Yeah, I think there are a lot of really good points there, Samir. And I think, the equity of access is something that has kind of been brought to light. And I think a lot of concerns are around, if this parity goes away, how are we going to continue to deliver care, especially with now, the fear around COVID and possible transmission, et cetera. I want to turn, Katie, to you, because from your standpoint, I know, telehealth parity has been a lot there. Remote patient monitoring has lagged behind, I think, to an extent, as far as the available reimbursement. So what's your reimbursement strategy sort of look like, and how do you kind of see that moving forward into 2021?
Yeah, thanks, Nolan. So, while CMS's public health emergency waivers throughout the pandemic have afforded providers like us flexibility to utilize telehealth and remote patient monitoring to meet those needs, as well as provide additional access for our physicians, there's still little to no payment from federal programs for these services provided by home health and hospice. It really has become a cost to us in providing the care, but we know it's the right way to deliver care and engage our patients and our providers. We are still, though, in early stages of payment alternatives through the Medicare replacement programs, commercial payers. It's great to hear what Rick and the Blue teams are doing. And so, we're really looking to continue to move that forward, continue to look at pay for performance models such as ACOs and physician group partnerships for shared risk and bundled payment. So I think these strategies are on the forefront of our mind, and we're continuing to work through that to ensure that we can continue to deliver this solution.
Yeah, I like what you said there, Katie. And I think to your point, a lot of this is looking at collaboration. And in a lot of ways, it's between sort of the three parties we have here, right? It's IDNs, it's post-acute, and it's payers working together to create strong quality of care that will ultimately drive down the cost of care. So Rick, from your perspective, we know that as a payer, you're working with different providers who have sort of those strong outcomes that you're looking for. Where do you see kind of your role in sort of supporting telehealth initiatives and supporting remote patient monitoring? And can you talk to us a little bit about sort of that decision-making process?
Yeah, so I'm going to answer that question along with the question from Christine in the Q&A. So just so everyone on here knows, we can see it. So if you want to start submitting, it's hard to believe we're already halfway through here. So I think to the point Samir made, while we think about parity, obviously being able to reimburse at what cost is a debate that's going to be had for the next probably couple of years. But in some ways, it really exposes the problem of not having enough value-based, outcomes-focused agreements between payers and providers. And that somewhat bleeds into what Katie talked about too, which is if you have to worry about what you will and won't be compensated for and have to make financial decisions upon that, you're making decisions that potentially could not always be in the best interest of the patient. Obviously, physicians have to make those difficult decisions day in and day out. And what we try to do, over 60% of the actual contracts we have are global outcomes contracts. They reward based upon the quality of care. And things like enabling more telehealth utilization, allowing the use of remote patient monitoring, et cetera, all within the construct of a value-based agreement that just rewards you for taking good care of that member, is where we believe healthcare needs to go as well. So to Christine's point, how do we actually get patients to be meaningfully engaged and sustained around using remote patient monitoring tools? Well, they need to see value in it. And I think the best way to provide that value is a sustained, ongoing, and as opposed to annually, monthly, maybe even weekly relationship with a primary care doc who's totally focused on just helping them manage that condition. And the best way that we as a payer can allow them to do so is to reward them for doing that effectively. So I think while we're still in some pockets of this country focused on fee-for-service arrangements and what that means from a parity perspective and what that means from a reimbursement perspective, the patient loses. We have to find a way to where the doctor can just focus on delivering that care, and maybe remote patient monitoring is a critical component of that care, and they should be rewarded for that. And by using that well in an outcomes-based agreement, they will. I think that's where the focus really needs to be immediately. And then things like parity won't be so much of an issue because we'll actually be compensating people for keeping them well.
Yeah, it's a really great point, Rick. And Katie, I want to get your opinion on this too, because I think that idea of kind of how do we engage patients in remote patient monitoring and in telehealth in general is the key component to all of this, right? So what have you seen from a post-acute standpoint? How do you get that engagement and how do you sustain it?
So this is something I am super passionate about. We've got to engage that individual in their own care and managing their care. And what we've seen success with is really getting to that bedside relationship with the clinician delivering care. So once they've gotten that engagement with the patient and setting up that access to telehealth and remote monitoring, as well as a simple platform, we find that, our patients, it needs to be easy, it needs to be fun. And so we get that engagement through that one-on-one relationship at the bedside, as well as, throughout the remote monitoring, having a simple platform that the patient can engage with. We find that there's varying levels, again, of patient caregiver support. And so also engaging that caregiver in this strategy with remote monitoring, we're seeing great participation.
That's a great point, Katie. And I think, to me, what I always look at is if you have good engagement in your telehealth or RPM program, you have good clinicians, because that's ultimately what it is, right? It's connecting good clinicians with patients to allow kind of more points of interaction, more engagement between those two. And I think that's always the most important part of connecting them. Samir, I want to come back to you, and I think Rick did a really nice job sort of outlining some of the ways that payers can collaborate with providers. How do you see that from your perspective? Where do you see that collaboration being most valuable, and what are some of the kind of things that you're looking at for this year in terms of value-based arrangements and other partnerships?
Yeah, it's a great point. I think the collaboration between the payer and the provider side is essential. We tend to oversimplify this by saying value-based or fee-for-service with some risk associated with it. The devil is in the details. I think over the last 20 years, I've forgotten a lot of medicine, but I've picked up a lot of contractual knowledge expertise that sometimes I wonder, am I doing a lawyer's job or a doctor's job in a particular meeting? So I think continuous collaboration and conversation between payers and providers, because we're both trying to solve for the same problem, which is better health of our community, but we come at it with very different angles and historically somewhat of a challenged relationship that I think has to be overcome through good partnership and understand that, good outcomes for the patient will lead to good business outcomes for both entities. And this is not a zero-sum game for either the payers or the providers, but unfortunately, that's how it plays out in certain situations. What I would also like to reflect on is that telehealth has materially changed the future of what it means to be a doctor and the future of what it means to be a nurse or in acute care. I think Jason just asked a question which makes me go in that direction is, do we see a specialty in the future that is around becoming, virtual care? So I think the answer is absolutely yes. If you look at the hospitalist movement, and I am an hospitalist from a clinical perspective, when I used to practice, that came about because just that single doctor running to the clinic and then making house calls and then running to the hospital where the patient has been waiting for 6 hours, and just the explosion of medical knowledge made it necessary to go in that direction. I think the same is going to happen with virtual care. It is going to become more specialized, and we have to acknowledge that thinking that a doctor can, or any provider, nurse, can stop what they're doing in the physical space, pick up the phone or a tablet and then do a virtual call and then put it aside and go back to doing what they were doing is silly. That's the kindest word I can use on a recorded setting, but let's just call it outright silly. So we're starting to do things where people have protected blocks of the time that, Monday afternoon, all I do is video visits, and then Monday morning I'm doing rounding, and then so on and on. But I think people will declare a liking and an expertise to that. I just want to be your virtual care provider. And that's what I do every day, so that I can develop an expertise and empathy and give people a much better experience. So I firmly believe that the innovation in the space of telehealth will be less about technology. That's no longer the barrier. It's about how we measure, define the experience for me as the one giving telehealth services, and for people as patients receiving telehealth services. So it's the experience of both entities.
I love that point, Samir. I think one of the things we always talk about at HRS is telehealth is a skill, right? It's not something where, like you said, you can jump back and forth necessarily. It's an option, but what you really want to do is find the people who really have that skill to be able to deliver excellent care through virtual mediums, and reward them and build programs around them, and be able to kind of enable them to do more. And I think that's a really, really important point for a lot of organizations to think about.
Yeah, let me add one more thing very quickly. I think you first have to define what is a good experience. We haven't defined it. Because COVID was a pandemic response, we said, here is your iPhone, here is your laptop, here is an internet connection, here is this particular video-based platform. I won't pick one because I'll upset the other one we use. So, just go ahead, knock it out of the park. And we did. But now the patients and us are realizing, okay, that was a telehealth. I took care of the problem, but was that a good visit? No. How do you define a good visit? Nobody knows right now. So we really have to take a step back and say, what does the office visit of the future look like in the virtual platform? What does an interaction for Katie's team or Rick's team or my team look like, so that I can say, this was good, this was bad. So what I would submit, and I wrote this in one of the responses, is that we really have to take a design-based approach, really think about what is the job to be done in a particular situation, and invest some time and money in creating that experience, defining that experience, and then configuring our technology and the training that we give to ourselves, and managing our consumers' expectations to say, this was a good visit, this is why you should be happy, and this is why you should come to us. I think that's a whole body of work that we're just starting to get going on, and a lot to do there.
Yeah, I think, the term website manner, right, is a term that I think all of us have heard. And I think to your point, Samir, how do we quantify it? How do we actually measure and say, this is a good experience, this is what it looks like? I think that's such a great point. Rick, I want to turn to you. I saw there was a question that came through from Christine as kind of a follow-up, which was about sort of the relationship between providers and payers, right? From a provider standpoint, what do we expect to bring to the table? And also from a payer standpoint, if a provider is limited resource-wise or has part of the puzzle but not the whole thing, where does the payer sort of add value and resources there? Wanted to see if you wanted to address that question.
Yeah, in their actual chat back to her said, I totally agree. And there's a couple other things in the Q&A that I'll kind of weave in here as well around how we share data. I'll use that as actually a starting point. So our ability to be interoperable, our ability to actually make sure doctors have the information they need to be able to deliver care, our ability to actually synthesize and organize the various telehealth visits someone might be having across 5 different entities, and helping their primary care doctor know that all of this occurring is a frontier that we still have to go through. There is a lot of work to be done in that space. There's a lot of focus and energy but we're not where we need to be. And then you add in things like capacity issues. So yes, if we're going to ask physicians to take on more onus of that relationship, and then as Samir says, they have to figure out how to manage their 8-hour, 9-hour, 10-hour growing day, going between telehealth visits within their state, telehealth visits from another state, and then the arrangements they have with the members that they had before that, that's incredibly complex. I would love to sit here and tell you I have the answer. I don't. I think what we're trying to do and provide value is, again, try to do to the best extent possible all we can to make the information that we're collecting across all these entities available, make it relevant at the moment of care so that the physician that's providing that care understands everything going on with that patient, and then removing all of the other things we talked about earlier through agreements that actually reward you for being able to do this well and focused on patient care. I don't have a great answer as to how we're going to get there yet. It's something that we're actively as a company working through. We have entire teams focused on how we can play a better role in supporting providers and delivering that care. But we have a lot of work to do, to be honest.
Yeah, I think it's been really interesting to see this play out with Rick talking to you and looking at kind of our customer base as far as what are the roles of the different organizations when you enter into these agreements and partnerships together, and who brings what to the table and all that. One thing I want to address quickly, Rick, before we kind of move on out of the reimbursement topic is, I think one of the questions I always get from our partners is about wanting to get into sort of kind of arrangements with payers and having the desire to do so, and wanting to know, how can I differentiate myself from the rest of the group? What do I need to bring to the table in order to kind of come to the top? I think you talked earlier about kind of a marketplace of different providers and programs. Yeah. So what are the things you would look for, tell an organization that said, hey, we want to partner with you?
Yeah, obviously, as I said earlier, we are moving entirely towards being able to have our entire set of provider options in some sort of agreement that rewards value, outcomes, et cetera. So some of the entities that we worked with in 2020, all of them are in agreements that allow us to work through some sort of case rate, some sort of defined per participant fee, some sort of quality focused arrangement. Because I'll be honest, as a health plan, employers are our customers, and that's what they are demanding as well. They want to know that the care is being delivered, is appropriate, relevant, needed, and of high quality. And our job supporting our customers is to make sure that is happening. And the best way to do that is through agreements that reward providers who are able to provide better patient care. But I won't deny the experiential component. Things are changing. There are companies that are startups that are bringing an unprecedented amount of access in a way that is really easy to use. We talked earlier about audio care, video care, chat-based care. We're now at the point where you don't even need to speak to someone, and a lot of conditions can be solved for and symptoms can be understood. And one of the cool things that comes from something like that, when you think about artificial intelligence from an experiential perspective, we have found, and research has shown, that there are a good number of patients who are willing to share something with a bot that they won't share with a human. And that is because they know that they will not be judged. Those types of experiential factors matter. So while we focus on cost and quality as a system, and then as a healthcare ecosystem, that is, the experience piece is becoming something where there's a battleground. And being able to show something differentiated there is critically important as well.
Really helpful points, Rick. And I think that the experience piece is absolutely so important, right? From start to finish, you want to have a technology experience that's simple, that's easy to use, and that gets you better results than what you previously getting. We need to have a better mousetrap, not just the same thing that we were doing before. There's an interesting question that came in that I want to pose to you first, Katie, and then I'd welcome any thoughts, Samir and Rick, from you as well. So this question is about the medical devices that we see coming out now. There's a lot of talk about continuous monitoring, about remote stethoscopes and other devices that can kind of give us better diagnostic tools and better RPM tools. So the question is essentially, are the current tools sufficient? What are the needs for additional devices, and kind of where do you see that playing out over the next kind of year?
Yeah, I think I'll kind of go back to how I opened up, that we're finding it's not one size fits all. So I think, the device and the hardware and the tools really have to be customizable to that patient, their need and their access. Another point that we've talked about, here with Rick and Samir is that, we need equitability across these patient populations, and not all patients have the ability to get that smartphone. And so how can we get them access to care, without having to go and make an investment in that technology. And so I think there's still much to be discovered about what tools and hardware will be successful across these different populations, but I definitely think there has to be multiple options and solutions.
Yeah, I totally agree with you, Katie. I think the multiple options, right? There's not going to ever be one hardware device that works for everybody. And I think, one of the considerations that gets lost a lot is there's sort of newer, exciting devices that might have continuous monitoring or other pieces. But Samir, to your point from earlier, in terms of equity of care, there are some devices that just financially aren't viable at a large scale to be able to roll out. I'd be curious, Samir, on your thoughts on this kind of same issue and what devices have you seen?
Yeah, so two things here. And it's not that we need new technology. It's very similar to what Katie said. How can people create hardware and software that can be used by people who can't afford to buy $1,000 phone and $100 monthly plan? That's just not in the realm of their reality. And I would submit to you that is majority of the country. We are surrounded by people who are like us, so we think that's what the world is, but it couldn't be further from the truth. So that's one. And I think your original question was, how do I, as somebody who is in this space or wants to get into this space, generally differentiate myself? I would say, focus obsessively on usability and be able to clearly show a difference in outcomes for a patient. So if you can't solve the access issue, if you can't improve the experience while reducing the cost, and you are not delivering better outcomes, then it's a waste of your time and my time in exploring the art of possible there. Because if I am to go to somebody to say, hey, your experience of this telehealth visit will be better, but I need you to spend an extra 10 grand a year, give or take, on your side, which is, just you have to do it. That's a non-starter. Or if you come to a healthcare organization and say, oh, wouldn't you want your patients to have a better experience? Yes, then here is something you have to buy at a, $500,000 or $2 million annual subscription for you to provide this much better experience with no guarantee that it improves outcomes. So you have to take a step back and think, what problem are you solving? And be less focused on that I have AI or ML or the latest IEEE standard on video-based visits or blockchain, which is just going to change the world. So unless your device is generating free Bitcoins for me, I am not interested. What I really want is outcomes for our patients and a better experience for our healthcare system in doing what we are stretched every day to do on behalf of our communities. You have to be able to share your point of view and then document it with evidence.
I like how you put that. And one of the examples we always talk about is, do you need a Porsche or do you need a car that's going to get you from A to B and have more of that ability to get from A to B than to be able to spend all your resources on one Porsche, right? We need something that's going to get the job done, and we don't need it to be fancier than it has to be. So I think, when you look at the new devices that are coming out, those are a lot of the considerations that sort of get lost in that shuffle is what is the usability? Is it affordable? Is it going to give us better equity and access? There's another question here, Samir, before we kind of move on, that I think is sort of relevant to you, which is about the kind of interoperability of documenting telehealth visits, because now we're using all these different solutions across the enterprise, and how does the primary care doctor actually get access to see a patient's history when that's happening? So can you talk a little bit about interoperability from your perspective and some of the work that's been done?
Yeah, absolutely. We don't have time today to really define interoperability in the ways that I think it needs to be explored. It's often a topic that a lot of people have assumptions about what they mean when they're talking about interoperability. In its worst form, it's, take everything you have on a patient in point X and then give all of it to point Y and send it back every day. That's all you do. And now you have interoperability. So what changed? Except my storage costs went up as a CIO. I really don't have an outcome to show there. So let's put that aside for a second. at least in my personal experience of my ecosystem, and I want to share that humility. I don't have, the experience that smaller group practices may go through, but in our mid-size integrated delivery network, we have 2 or 3 solutions that we use for video-based visits so that we have redundancy in this very important capacity. We are doing more and more integration with our electronic health record. So A, not only does it get launched from our ecosystem, but B, we are working to make it easier and easier to document right back into our ecosystem and look at what the patient what has happened for the patient past. But again, as we expressed earlier, we're learning how to get better with it, not just from a workflow, but from a technology and data, moving the data perspective. So at least from I would say a mid-size IDN perspective, that hasn't been that much of an issue. But I do want to express the humility that I cannot speak for smaller practices or primary care doctors who don't have access to, or any doctor who does not have access to a full-blown technology and digital department.
Yeah, I think those are some great points, Samir. And Rick, I'd love to get your perspective on this too. I know you've done a lot of work with aggregating data that we're kind of gathering from these sort of telehealth visits, from remote patient monitoring. So how do you see kind of that flow of data, and what are some of the benefits or outcomes that we can get from learning more about what we're doing?
Yeah, I think for better or worse, the carrier sits at the intersection of every single provider we work with. So I'll use myself as an example. I don't have a primary care doc, but if I did, I've used 3 different services just in the past 3 months, and none of them know I've communicated with the other, but Premera knows that. And our ability to actually allow our providers to understand what I might have used those services for is critically important. But obviously there's considerations around that too. I mean, if you ask a general person, do you mind if your carrier starts sending all of your information to the doctors around you? I bet the answer would be no, because they don't think necessarily that we're going to be able to provide that value back to them in a way that's meaningful. So we have to be able to demonstrate through interoperability that we are improving outcomes, that we are actually delivering better care, and that it will be relevant to them. It's interesting, I've said this before, how many people, when you open your iPhone, allow everything you do to be shared back with the developers? It's the 5th question they ask you. And I bet 90% of the people on this call absolutely say, sure, everything on this phone share back with Apple, never thinking about what that might actually mean or what it is you're sharing. But if I ask people the same question as part of their enrollment in Premera, my guess is I get a no 90% of the time. So I think they don't feel like they're getting value from that sharing. And we, as obviously an entity in collaboration with the provider partners we have, need to make sure they know they will. And I think that's where we really have to focus for the coming years.
Yeah, it's a great point, Rick. One thing that I think is really exciting to me about the new developments that we've seen with RPM and telehealth is that the amount of data that we're able to kind of parse through and be able to identify trends to see what we're doing, I think is really exciting. And that seems to be continuing to improve. So that's an exciting trend, I think, for this year. I want to address another question that came in. And Katie, I'm going to turn this one over to you. So the question is, what's the perspective on at-home care and house calls, and how does it fit into chronic care management, long-term care, women's health, other kind of organizations or programs that you have? Because I think, from a post-acute standpoint, when you look at home health and palliative and hospice, there's always going to be some element of in-home care, right? So how do you see that playing out as telehealth continues to develop?
Yeah, I think that's a great question. And I think, there's ongoing evidence that shows, the ability to access care in the home ultimately yields better results and outcomes. And so where possible, I think if we can afford that to our patient population, we're all better served. We've been pleasantly surprised with the adoption we've seen even in our hospice business line to virtually connect our patients with their interdisciplinary team, therapist, chaplain, nurse, music therapist. And we're continuing to expand that reach, to, address behavioral health needs, as we've talked about earlier in this call. And we continue to see that when a patient has the ability to access care on demand, access that care from home without risk of additional complications, exposures, or adverse events, COVID case in point, they can accelerate their recovery and stabilization. And so I think, this transition and this acceleration of adoption of telehealth solutions is really going to afford us, I think, greater outcomes for our patients.
Yeah, I totally agree with you. And I think that's the piece that sometimes is missed, is that this isn't replacing, right? It's adding. We're adding more access. We're adding more ways to connect with the people that you want to be able to connect with. And I think that's such a great way to look at, how this is going to develop. The reality is that there will always be a place for in-person care, but we can build on that and actually improve the experience by adding on virtual elements to it. One question that we have here from Tony, which I think is a really interesting one, is talking about KPIs of value and quality, right? We've talked a lot about how it's all about the quality of care, right? So Samir, I'll turn this to you first. How do you quantifiably measure that? And how do you say, hey, this is what we look at for, the most important KPIs when we're measuring our success as a telehealth or virtual care RPM program?
Yeah, I think it's an evolving space. We started from very rudimentary KPIs. Did the visit even happen? Did the technology work? Did the patient get the scripts that they needed post-visit? So very basic KPIs of what would you say is quality and value. But thankfully, we have moved away from that and are really now starting to look at, did you feel that you had a visit that took care of all your needs in the moment? We have now started doing something that is very basic, but I think phenomenal, which is where we ask patients to give us our NPS score, not just on face-to-face visits, but also on our video-based visits, so that while it's, more of a descriptive analytics, not a diagnostic analytic, we're still able to see how well are we doing in their minds. But I think there's a whole body of work to be done, and a lot of people are laying stake that they are the ones who will help us define it. So I would encourage everybody to get involved in this, payers, providers, experts from a usability, because otherwise somebody else will describe it in a way that doesn't make sense for you. But I would also submit that, as much as we are looking at the KPIs for experience and quality, let's not miss another opportunity. This is not the first opportunity. Let's not miss another opportunity to redefine access. When I became a clinician too many years ago, what access meant was that you get to see me in my office at a time that's generally convenient to you. However, what access means right now is now it's focused more on me as the patient, that you are able to answer the question I have and solve for the needs I have in the moment where I am, at a price point that is acceptable to me. So as an example, if all I need to know is that, true story, the school tortoise bit my 8-year-old's thumb, I was like, there's no way I'm taking her to the ED. I'm doctor enough to know that she's not going to lose her finger. Okay, do I take her to urgent care? And I was like, no, I don't want to wait in urgent care. And thankfully, my health system at that point had a walk-in clinic. So went there very quickly. $20 later, she got a nice colorful bandage and a lollipop. And I realized even that was a waste of time. What I really needed was somebody to get on a video call. I showed her thumb like this, and they ask a few questions and we are done. I would have paid $50 for that, because paying $20 in the walk-in clinic literally wasted 3 hours of my life on a Friday evening. Versus if you say, Samir, you can come into our clinic, which has a wait of half an hour, and it's $20, or I can do this on the phone with you on a video visit and it's $50. I have a choice. I may not pick that choice every time, but I have a choice. And access has to take into account choice and valuing people's time, and not just the other parameters we have right now.
That's a really, really great story, Samir, and thank you for sharing that. I think it's such a great point to illustrate that, hey, there are really a lot better ways to do what, these common problems that we face, every year in our lives. We face a similar situation to that. I know we're running a little short on time, but Rick and Katie, I'd love to get your final thoughts on this sort of value and quality standpoint.
Yeah, I think obviously this is a frontier that has finally arrived. I think our ability to successfully integrate all of the capabilities that are being brought to bear, while also preserving the things that were really good in 2019 and before, is really how we be measured going forward. I can tell you in our space, that's where we're wholly obsessed on doing and continue to focus. And obviously, Samir and Katie are great representatives of the provider side and how we can collaborate with them more effectively to ultimately benefit the patient, which is really what we're all trying to do. So I've enjoyed today and I appreciate you having me.
Absolutely. Katie, I'll give you one final chance to give your final thoughts too.
Yeah, no, we've just seen tremendous improvement in our ability to affect outcomes utilizing telehealth and remote patient monitoring. And, so much so that we've been able to meet or exceed state and national benchmarks for rehospitalizations and patient satisfaction. And so we just continue to experience positive results with these solutions. And as Nolan so nicely put, as an adjunct to that in-person care. And so I think those two combined affords us a lot of opportunity to have an impact in our community well-being.
Thank you so much, Katie. And thank you to all the panelists, Samir, Rick, and Katie. This was such a fantastic way to learn about telehealth. I hope this was valuable for everybody who stayed on with us. Thank you for joining. We're so excited just about this year and where telehealth and RPM will take us. So we look forward to continuing the conversation and appreciate everybody's time today.
Thank you, Nolan.
Thank you to Nolan and all our panelists. If you'd like to continue the conversation, please join us on Twitter. And now, please welcome mentalist Mark Tolan.
Hey there, everybody. It's great to be here. Thank you for having me again, Health. I appreciate it. Looks like we've got a few volunteers staying on. How many are we going to have? We got Nolan, we got Katie, and we've got Eddie. Great, fantastic. And just want to make sure I can see you. There you are. Fantastic. Okay. Great. So thanks for staying on, you three. We're going to try some quick virtual mind reading today to round out the webinar. Just a little change of pace, a little entertainment before everyone logs off. So thanks for staying on and helping me out. There is something to keep an eye on during our short time together, and that would be this bottle right back there in the corner of the shot. I will show you. It is a message in a bottle. It's got a little slip of paper there. It's a message in a bottle. It'll be very important towards the end of our time together. So for now, I'll leave it back there. Just keep an eye on it. First off, just quick warm up with the three of you here, and that would be just to see maybe if we can all get in sync. So I'm going to give the three of you a chance to maybe pick up on something I'm thinking of, and we'll see which one of you can get the closest to it. And that will kind of steer our time together. So we'll use this actually, which is a pack of cards. And I'm not really a sleight of hand guy, but it's good psychologically because you guys know what these are, and I'm thinking of one of them, and that's our test, is to see if you can pick up on the card I have in mind. And just so everyone who's watching on screen and off will know what it is, there is one card in here that I took out and I turned over in the middle. So that means there are 51 cards going one way, one card going the other. We'll call it our target card. You'll know when you see it because it's reversed. So Katie and Eddie and Nolan, if you would, I'm going to have you each try to work out what this card is in your mind. Obviously, don't say it. Don't tell me what it is quite yet. But get a card in mind. It's not going to be the Ace of Spades. It won't be the Queen of Hearts. It won't be the Joker, right? Those are too obvious. So if you want to change your mind a few times to make it more specific, that's the way to do it. Narrow it down to one card. And once you have a card in mind, just give me a thumbs up so everyone who's off screen knows as well that you are each thinking of a card. Let's see, there's Nolan, there's Eddie, and there's Katie. Very good. Okay, so let me look at the three of you now and see. I think let's just talk with Katie and Nolan. And this might just be because Eddie has just come on screen to help us here at the end. But just because I was watching Katie and Nolan a moment ago and hearing you, I might feel maybe slightly more connected to the two of you. So if I could chat with both you, Katie, what was your process for the card? Did you go straight in on it, or did you change your mind a couple of times? Just tell me your process.
I went straight in on it, and then you told me I couldn't choose it. So.
Oh, so you did go for a common one, and you had to change your mind off of that.
Yep, but then.
Okay, that's good. That's good. That's why I say that, because it's what people think of all the time. So it's not mind reading. That's just statistics. Nolan, for you, what was your process? Did you change your mind a few times, or go straight in on the card? What are we talking?
I went straight in on the card. For some reason, I just have this feeling that I got the right card, so I didn't waver. I was just like, this is it.
Interesting. Okay, I like this commitment. Okay, so actually, I will stick with you then, Nolan, because I had a feeling about you as well, and obviously you did too. So Katie, don't hate me here, but we'll go with Nolan. But out of curiosity, Katie, and since you're like runner up here, the other card, what would it have been? What was your card that you ended up on there?
10 of Hearts.
10 of Hearts. And Nolan, that was not your card. I'm hoping different card. Very good. Obviously, if anyone out there is doing this and thinking of a card, you had a different one in mind as well. So Nolan, I'm saying it's you on screen with me. Sometimes I do this with hundreds on screen. We're doing it with just the four of us here, but I'm saying, I think if we're right, I think maybe you are thinking of my card. This would be amazing if that's how it is and get us off on a high note here. So tell everyone, what card did you think of? What was it?
I thought of the Jack of Diamonds.
Jack of Diamonds. Jack of Diamonds. Okay. Interesting. You just went straight for the Jack of Diamonds. That's exactly what we want. I'll be very slow and fair, but I want you and everyone else to see. Obviously, here are the cards. And in the middle, as promised, there is one card facing the other way. Who's setting a card? But Nolan, clearly we are in sync because you nailed it.
Nice, very good.
Very good. Okay, awesome. We're off to a great start. So let's come back to Eddie here, since I didn't use Eddie for the card a moment ago. And Eddie, if you would, let's do something more personal. And I want to make sure I'm staying on time for you guys here today. So I'm just glancing at the time. But Eddie, would you think of a memory from your life that, you know, is a little more random or specific than what people might go for? Just like with those common cards before, people tend to go for a birthday or an anniversary or a holiday or something. So make it a little more specific, a little more random. Don't say what it is. Just let me know when you have a memory in mind.
Okay.
You got something?
Yeah.
Okay. Very good. Now, Eddie, look, if this was my memory chatting with you on Zoom today after the webinar, it's 1:05 here in Chicago currently. So that's the time I would associate with this memory. So if you would think of a time that relates to your memory, right? You probably don't know the exact time, so just come up with one now that feels right. Morning, midday, afternoon, evening. Just create a time. Don't tell me this. Just let me know when you got one. Okay, very good. And then, Eddie, if you want to challenge me, if you want to make this a little more specific, you could take a couple minutes off because it's already changed here. It's 1:06, right? So it doesn't have to be exact. It doesn't have to be 1:30 or 1 or whatever your time is, right? You can add a couple minutes or take some off. Don't tell me. If you want to make it more specific and challenge me, you can. Just let me know when you're locked into a time.
Yeah, until locked in.
Okay, very good, very good. So look, let me take my watch off here. Here we go, just past one here. Eddie, if you wouldn't mind sharing with Nolan and with Katie, if you wouldn't mind sharing this memory, whatever this story was you were thinking of, if you wouldn't mind sharing with everyone, I'll try to use that information to guess the time. So just tell us the story, but not the time.
All right. So the first time I went ice skating, I actually fell and cracked my jaw, and then had to go to the hospital and get surgery after. So.
Oh my gosh.
Yeah, you said you wanted random, so there you go.
Okay, no, that is random. Okay. You said first time though, so you must have gone back out and kept skating.
Oh yeah, of course. After.
Well, it could have gone either way. That's how these things work. Okay, so first time ice skate. How many years ago are we talking, Eddie?
Probably 10.
Oh wow. Okay, great. Oh, this is good. Okay, I'm gonna go with this for you. I think this feels right. You have a time in mind, yes? Hours and minutes.
Yeah.
Okay, just going off what you said, I'll just lock this in here. Give me 1 second. It's a great memory, and I appreciate you sharing that. Okay, I will commit to this. We'll say this. I'm completely locked in. So Eddie, tell everyone, could have thought of any memory, could have put any time with it, really, whatever fits. Right. So what time did you think of?
2:30.
2:30. Oh, so you just kept it even. You didn't have to, but you didn't try to challenge me. That's good. 2:30 could be anything. This is what I went with. Very slow, very fair. But this is what I went with.
All right.
2:30 on the dot, Eddie. We nailed it. Amazing. 2:30. Hate to dredge up those bad memories of the hospital visit, Eddie, but 2:30. Fantastic. Yeah. Amazing. As always, I've done 10 of these health events or something now with the team. So big thanks to the health team for having me on again today, and those of you who are staying to enjoy something a little different from your normal Zoom meeting. I'm sure it's very interesting to have a mind reader come on here at the end. So big thanks to the team and those of you watching. One last thing I'd love to try with you, Katie, while we're here, something that is really genuinely the hardest thing I know how to do, in person or virtual. We'll give it a go, and I just wait till the end to try it, just because I kind of got to ramp up to it, but I procrastinated long enough, so let's give it a go. Do you have your phone? Do you have your cell phone there?
Mm-hmm.
Excellent. Pull up the internet, Safari probably, if you got an iPhone, or Chrome or whatever it is. I'll grab my calculator so we can do this. Make sure I'm clear. We'll do a quick calculation to show everyone who's watching the scope of what we're going to try to do together, Katie. So the best way to do this is just Google how many articles are on Wikipedia, right? So a bit of a mouthful, but I'm going to show everyone how many, because this is what we're dealing with, and it's more impressive if people realize. I'm aware, but I want everyone to appreciate how mind-blowing this is. Katie, once you have that, if you could hold up your results there so everyone can see. If you just flash that towards your camera there so everyone can see what came up and they know. Perfect. Yes, very good. And then you got your brightness down a little bit, which is fine. Katie, usually what comes up is something like wiki. The best one is like wiki count or something like that. Do you see anything like that? Yeah, there we go. Okay, yeah, this will give us a count. We could really use anything, but this will work. Show that one more time and just freeze there so everyone can see. Yeah, exactly. So this gives us English article count for today on Wikipedia. It's always changing, right? But this is today, 6.2 million articles. And what does it say down below there? Average of approximately, what is that, 1584 or something words per article? Okay, so hold that back up to me, 1584. If I do this times the big number, 6252, 224, and then hit equals. That shows us how many words on Wikipedia. That's why I do this, 9.9 billion. And obviously it's always changing as people update. But the point is, it's a lot of words, Katie. That's what we're dealing with. So scroll down there and tap Visit Wikipedia. So that'll load for us. And once it does, if you would show everyone that you're on Wikipedia now, so everyone knows where you are as well. Perfect. And that's the last time you have to show anyone. I appreciate you doing that. Just the nature of virtual. Tap that the magnifying glass up in the corner now, Katie. I'm going to have you search for something on Wikipedia from your life. I'm talking a famous person, a location, city, landmark, country, whatever, a food, an animal, a hobby, any of those things. We just need an article, so you can't ask a question. It's got to be like a general topic, right? But it doesn't have to be fancy. It doesn't have to be extravagant. Just something connected to you in some way. Search for that, pull up an article, and let me know when you have the article. Obviously, don't tell me what it is, but let me know when you have something.
I've got it.
Okay, very good. Now we're going to randomize this more. So keep the phone in front of you, but look at me and not down at your phone, right? So you're holding the phone here, but you're looking at me, and start scrolling the article without looking, right? So you can probably see it in your peripheral vision. Just don't glance down because we're randomizing it. Good. Keep scrolling and scrolling. Whenever you're ready, stop scrolling. And now look down in the article and find a long word to think of. I'm talking 10, 12, 15 letters and something random. So not what you search for, not connected to what you search for, a very random, longer word. And once you have a word in mind, Katie, just put the phone against you like this so everyone knows you are locked in and committed to a word and can't change. Excellent. Okay, thank you for doing that. This is one word out of 9 billion plus words that you chose. I'm going to do my best to work this out. So imagine this word is written in front of you in big letters. That's the best way to do this. For now, Katie, would you tell me, is it a longer word, at least longer than like house or tree or car or something?
Yes.
Okay, good. Long word. And also, is it connected to what you search for, or is it random?
Random.
Okay, that's what we want. All right. I'm going to go with something like this for you, actually. Would you think of the first letter? Think of the first letter of the random word, not what you searched for, right? Just that first word. I'm going to go with this. Is that, oh man, I hope I'm right. Is that an R? First letter.
Yes.
Yes, very good. Okay, R, very good. Do the whole word now in your mind. Obviously, we're connected. This is good. Do the whole word in your mind. Don't say it. Just picture that whole word. What would it be? It would be something along these lines. Oh, actually, I get it. Hold on. I'm going to change that. This makes more sense to me. I just don't want to miss here at the end. That's why I told you this is the hardest thing I do, and I save it till the end. I will stick with this. I will commit to this. Obviously, a lot of words you could have thought of, right? You could have searched for anything. You could have stopped scrolling wherever you wanted. You narrowed it down to one word out of 9 point something billion words, whatever that number was. Would you tell everyone not what you searched for, keep that secret, but what was the random word? What was the random word from the article?
Recommended.
Recommended. Okay, so something like this.
Yes.
Amazing. Amazing. That is fantastic, Katie. Obviously, we were connected there. Now, don't tell me what you searched for, but before I let everyone go, I just want to know, is it from your life? Is it connected to you in some way, even loosely?
Yes. Mm-hmm.
Okay. This bottle has been back here the whole time. Someone's always keeping an eye on the bottle. It's got a little message in a bottle, actually, like I showed you at the beginning. We need to get that out now. In order to do this, I need, here they are, these weird kind of tongs here. So give me 1 second. Okay, sometimes it gets stuck. I just want you to be able to see this on video. So I'll be very slow here. I don't want to drop it. It's kind of challenging to do, but there we go. Okay, good. This is today's message and ball. Every morning when I have a show, I do the same thing. I sit down with a piece of paper like this, write some ideas of stuff I think is going to happen during the show. And then I fold it up and put it in the bottle, and it's back there the whole time. So someone's always keeping an eye on the message in a bottle. This is it now. If we review, a lot has happened. I came on, we did a quick test with cards. We ended up using Nolan and Katie for that. Nolan, you nailed it with the card. We were dead on. But Katie, actually, you had the runner-up card, the other card, as it were. So what was that other card again? Do you remember?
10 of Hearts.
10 of Hearts, right. So I was trying to imagine not only maybe my target card, but what the runner-up might be, which if I said this, I said the other card will be the 10 of Hearts. Right, so that was my first general thought. And then later we were talking to Eddie about a memory, and Eddie, you were telling us a story from 10 years ago, and I was able to guess the time, remember, 2:30. But Eddie, I'm more interested in that memory now, the story, and we all remember what happened. And I asked you if you kept ice skating after that, but you told us you fell, you hurt yourself while ice skating, had to go to the hospital. But obviously everything worked out in the end, you're still ice skating. But this is what I went with. It's not always exact, but I think this makes sense where he said, today's memory will have to do with falling while ice skating. Falling while ice skating. I think that's perfect for you. I think that makes a lot of sense. And then finally, last but not least, Katie, it actually ends up back with you, but this is just random with the three of us on screen now. You can bring us full circle now, and there's one piece of information that no one knows, and that is whatever you thought of that is kind of connected to you in your own life, whatever that was. So what was it?
For my 30th birthday, I went skydiving, parachuting.
Oh, fantastic. Oh, wow. Yeah. Skydiving. Okay. Skydiving. All right. Could be anything. Well, this is what I went with. I said, and the secret search will be skydiving.
Wow. Impressive.
There you go. Big thanks to Katie, Nolan, Eddie, and the whole team at Health for having me today. I've been Mark Tolan. Guys, enjoy the rest of your day. Thanks so much.
Thank you, Mark.
Thank you, Mark, and thank you, everyone, for joining us. Have a great rest of your day.